Hello everyone, welcome to Class 6, Calling Consoles and Working the Team. I'm Jared Dashevsky, founder, creator of Healthcare Huddle, and creator of this course, Intern Year Bootcamp, the course I wish I had going into residency. And this course is in partnership with Doximity, whose tools I've been highlighting throughout this course so far. So last class, we talked about setting yourself up for success and how to delegate tasks, how to prioritize tasks, and how to get them done in an efficient manner. One of those tasks that you'll be doing is calling consults, but also working with the team. So we'll first start with the consult part, and then we'll talk about, or I'll give you my tips and tricks for working within an interdisciplinary team. Okay, because there's a lot of important things to talk about, especially as you grow older in residency and become jaded and fed up with a lot of the stuff. But foremost, calling consults, probably the most dreaded task for medical students and interns. I'm sure you remember as your sub-I or during your clerkships or acting internships, that calling consults very anxiety provoking, very kind of scary. And if we take a step back and think like a therapist or a psychoanalyst, psychodynamic, it probably has something to do with our parents. I'm just kidding. But the reason why they're so scary is because there's a lot of unknown, and we want to come off as competent, but we feel like, or we fear that we're coming off stupid. And this is such a valid fear. Like I to this day, I still hate calling consults, but they do get easier. Let's take a step back and think, why do we call consults? Aside from the attending saying, let's call a consult. For you as the intern or the resident, why do we call consults? We call consults because we need help with managing a consult specific or specialty specific question, because we have run out of options. Like we've done everything we can to work this up, to manage it, and we've reached the point where we just need a specialist. And so think about what I just said carefully. The point at which you call consult should be the point at which you've already done the workup and tried managing it, and now it's beyond your expertise. Okay, so a good example would be nephrology, right? Patient has an AKI, right? You learn about AKIs in medical school. You should know how to work them up. Okay, so if you have a patient who comes from the AKI and you suspect that it's prerenal, and you give fluids, and the next day the creatinine's worsening, okay, and you give some more fluids, creatinine's still worsening, then you end up getting a renal bladder ultrasound. You stop all nephrotoxic agents. You hold their ACE, their ARBs. You avoid certain medications that impact the kidneys. What else? You get urine studies. You get a urinalysis. And if all that is kind of unremarkable, you've done your workup, right? You've done the fluid resuscitation. You've done the imaging. You've done the urine studies. And at that point, you're kind of out of options. So only at that point is it really beneficial to call nephrology and be like, hey, I have a patient with worsening creatinine. We've given fluids. Can you help us? Right? Can you help guide management for this AKI? Okay, so that's the point at which you should call consults. Of course, you're attending, and you'll have attendings, and it will be annoying, that are very consult heavy, where they perhaps don't like taking on the responsibility of working up certain things like an AKI, and they just say call nephrology, or a patient with AFib, right? As internists, or me, we can manage AFib. If you're a surgery resident, right, there's no reason that you should know how to manage atrial fibrillation, just like how me as an internist, I don't know how to remove a gallbladder. So at that point, it's okay to consult cardiology or the medicine team, like me if I'm on medicine consults. So the way to So that's at which point you should call a consult. But how do we actually lay the news or discuss the consult with the fellow or with the attending? And you can imagine being on the consultant end, right? And so as a medicine resident, like, we get consults from surgery teams, from neurology teams, from neurosurgery, right? You name it. And you learn really quick what a good consult is, right? So a good consult is succinct. You get the consult question right off the bat, and then you get some information thereafter. So there's this method called the SBAR SBAR method. I'm sure you heard about it in all of your like intro to residency classes, and you're hearing about it in this intern year boot camp. But S stands for situation. This is your background information of the patient. This is your assessment of the patient, and this is your request from the consult. But truthfully, I always just start with this right off the bat when I'm talking over the phone or in person, right? This is a consult for AKI workup. And then you go through the situation. So, hi, I'm Jared. I have a new consult for AKI. This is an 80-year-old man with hypertension, hyperlipidemia, CKD3. He's presenting with sepsis, now has an AKI. When he was admitted, his creatinine was, 1.1. So now this is the background. So this is like the hospital course. When he was admitted, his creatinine was 1.1. We gave some fluids, and the creatinine keeps going up. We've held his any nephrotoxic agents, and we got urine studies. Okay? And then when you talk about the assessment, we think that this could now likely be something like ATN in setting of, maybe the patient was hypotension plus sepsis. However, we want your help in managing the AKI and any recommendations for further workup. And that would be the request, AKI management. And if you're concerned, management, and if you're concerned about something like maybe they're impending acute renal failure, you may just right off the bat be like, I'm concerned that they'll need like hemodialysis or some sort of clearance, right? Renal clearance. Okay, so situation is like the one-liner, and also say who you are, give background on the hospital course, talk about what your assessment is. I think the best consults are when the primary team has already done the work and they're thinking, and the consult really should be a learning experience. And it's concise. It should take less than a minute or two, and then the consultant will answer any questions. Okay? So how can we use our fellow Doximity resources for this? Okay? So let's go back to our example from a couple days ago. Let me find it. So Mr. John Smith. Okay, so let's say he presented on admission with AKI. So let me copy and paste this, or he presented with volume overload. Okay, so we can paste the admission note there, my made up admission note that my own AI created, and we can say we would in SBAR. Yeah, in SBAR format, can you consult is for the nephrology team. I'm just trying this out. I don't know if it's even to know what SBAR is, but we'll see. Excellent. Right, so maybe this helps you. Maybe if you're in a time crunch and you don't have time to really sit through the patient, and you have 5 consults to call, this can help. Hey, we're requesting a nephrology consultation for Mr. Smith, 75-year-old ESRD, Monday, Wednesday, Friday hemodialysis. This obviously doesn't make sense right now because the patient already has ESRD. Why the heck do we care about a AKI? So ignore this example. Let's try another example. Let me think about, do I have another example? Actually, let's say this. Do the same thing, but consult pulmonology, SBAR format, right? And the consult will be for acute hypoxic respiratory failure. Let's see what it says. Who's admitted for acute hypoxic respiratory, 4 liters needed cannula, progressive dyspnea. Here's the background. Here's the assessment. Likely secondary volume overload, cardiogenic pulmonary edema. we're requesting pulmonary evaluation for the respiratory failure, the pleural effusions, and that's it, right? So ignore the first one with the AKI on ESRD. I'm just seeing if you're paying attention. This one is probably best suited, okay? And many organizations use amion to communicate with consultants. So, and through amion, you can like page with text. So if we look at this, this is you're paging me, and you only have 160 characters. Okay, so maybe you go back here and say, "Thank you. Can you condense this into 160 characters so I can page pulmonology via amion?" And Doximity owns amion. That's a fun fact. Boom. And so you'll paste that there. You'll say from Jared, give your phone number 555-555-5555. But we round them spaces. So theoretically, you would include your number, and then here I usually include the patient's MRN, right? Their medical number, and then you click send, and then I'll get the page, and then I'll call you back. So that's how we can use the Doximity's tools to help us with consults. So transitioning to the next thing to talk about, right? So we don't need this anymore, but is working with the team. And I can't stress this enough. I delete all this. I can't stress this enough, but please, just for the love of God, be respectful and be kind. Everyone thinks their job is the hardest, and maybe it is. Everyone is stressed in the hospital. Everyone's in a rush. Everyone has to do a million things. Just be kind, because if it's very easy to get pissed off at someone else, and it just escalates, and now you're writing obscenities in the electronic health record chat. Don't do any of that, okay? If you are annoyed or angry, take a breather, go get some coffee, and actually ask to speak with the person you're annoyed with on the phone or in person. It's very easy to hide behind a computer and just like message angrily, but don't do that. So when you're working in the hospital, at least, right? And you're on the, let's say, medicine service, right? You, as the intern, are kind of like the center, the orchestrator of everything. You're coordinating care. My handwriting truly is atrocious. And you'll be working with consults. You'll be working with nurses. You'll be working with OT, PT. Who else will you be working with? You'll be working with social worker. You'll be working with a case manager. A lot of people, okay? And a couple things are very important for working in this team-based setting, right? You could have a whole course on how to work on a team, but I'm just going to highlight the ones that I've found most helpful in the hospital, especially as an intern. The first is closed loop communication, okay? And let me show you real quick what that looks like. You tell a nurse, or the nurse asks you to reorder restraints on a patient who is altered and pulling out their NG tube, okay? They tell you to place the order. Once you place the order, let them know that the order is in, okay? If you tell the nurse that you're going to order fluids for a patient, you say, nurse, or miss whoever, nurse whatever, I place the 1 liter bolus of lactate ringer solution. The nurse tells you when it started and when it finishes. When communication happens like that, everyone's on the same page, everyone's updated. If you ask the nurse, hey, can you draw labs? The nurse should confirm or close the loop once those labs have been drawn. For consults, maybe the consultant asks for a chest x-ray. You, the medicine intern, orders the chest x-ray, and then you let them know once that chest x-ray has been completed. And go above and beyond do a preliminary read of that chest x-ray and say, hey, chest x-ray done. It looks like there's a new consolidation in the right lower lobe. What are your recs? Okay. For case manager, they may ask you to pen the discharge summary so that they can start applying to subacute rehabs for a patient. You let them know once the discharge summary has been penned, right? Don't anticipate that they're going to be refreshing the chart waiting for you to do it, okay? Once it's done, let them know. For social worker, if a patient needs home health services, you let them know that they need home health services. The social worker may tell you to write like an encounter note stating why the patient needs home health services, and you close the loop. PT, OT, same situation. Maybe PT thinks that patient needs or would be suitable for like a rollator. Okay, so they let you know, and you can put in the order. So closed loop communication is key and probably the most important team tool to keep in mind, especially during a code if a patient is undergoing ACLS, right? Epinephrine. Epinephrine's administered. Someone says epinephrine in, something like that. Closed loop. Number 2 is transparency. Okay, transparency could be just like transparency with the plan, right? So on rounds, when you discussed with the attending and the senior resident what the plan will be for the day, you should let the nurse know when you see them. Just be like, hey, just letting you know, the plan is to continue with antibiotics today, give some fluids, and get them to work with PT. I anticipate the discharge will be in 48 hours, right? That's the type of transparency keeps everyone on the same page and up to date. The worst is when you're following one plan path that's not what another member of the team thought they were following, and lack of transparency leads to errors. And then the third aspect of working on the team is just to be kind, as I said from the get-go. I have a 2-year-old daughter, and obviously we're trying to teach our daughter how to be kind. It's tough. Visceral emotions definitely trump kindness, but just put a smile on your face, even if you have to fake it. When people are pissed off at each other, nothing gets done, and patients are the ones who are harmed in the end. Okay, so I follow these things very seriously when I'm in the hospital, and I like to think that my team as a resident when I'm running it runs quite smoothly. We get patients in and out of the hospital, families are content, the team members like the nurses are content. A last tip, try your best to remember everyone's name on the team, including the social worker, the nurses, the PT, right? Once you're talking to a nurse and you know their name, they know your name, it's much better than just barking orders when you don't have any sort of like relationship. And I guess that has to go with being kind. Name, remember. All right, and that's about it. So a little long class because I combined the consultant working with the team, but remember all this. It's easy stuff. Okay, closed loop communication, transparency, kindness, remembering people's name, and then when you call consults, remember that SBAR method, which I erased. And I'll see you in next class. And if you're watching this all the way through, good for you, because I'm exhausted.